or as they say in Gaelic, which is one form in Irish, Fáilte. Thanks for joining this webinar about staff roles and training for your fall prevention program. And a little bit about myself. I work as the accreditation manager for Ronald Reagan Hospital, which is part of UCLA Health System, the Department of Nursing. I have worked on quite a few national projects related to falls and given many national talks. And I've worked with AHRQ on a panel to create the Fall Prevention Toolkit, which was a very incredible experience for me. I also work on quality and safety issues in the hospital. Talk about the key elements of AHRQ's Fall Prevention Program: staff roles and duties, organizing a plan at the unit level, training on fall prevention practices, new ones, and these topics were introduced in your one-day training, and today we'll revisit them in depth. Please note of any questions. Your quality improvement specialist will follow up with you after this webinar and address those questions. So, program, of course, universal precautions, and as many of you are aware, all patients when they enter a hospital are fall risk, are high fall risks, but all are a fall risk. So you definitely want universal precautions in your hospital for all patients. And some of those would be like familiarize the patient with the environment, have the patient demonstrate call light use, maintain call light within reach, keep patient areas free of clutter, practice like those. Factor assessment. Definitely everybody wants a risk factor assessment for each patient. We use the Morse here at UCLA, which is validated most of the assessment tools that are out there, but still it's not perfect for the inpatient acute care setting. Care planning, so you want to make that individual to the patient. I really don't like checklist care planning. You can have broad categories, but really make sure that the personnel is really drilling down to who that patient is in the bed and what kind of care are you presenting to make sure that they decrease chance of falling or decrease in injury if they do fall. And then, of course, post-fall assessment, that's the mini root cause analysis tool. And this is really good for accountability. And I recommend that it's connected to yearly performance objectives. You know, if you do end up with a fall, that you have filled out this tool and have gone over the actual event. We definitely recommend that when it's filled out right after the fall, if possible, and involves the people in the care team that were part of that fall. So it could be the lead nurse, the care partner, and LVN if they were involved, and then also the patient and family members if you can get them on board. Definitely also make sure that your float pool is aware of the mini root cause analysis tool so that they also work in go over and filling out this tool if a fall happens to them on their shift. Staff roles and duties. Implementation team, the roles and duties, so those are the people that will roll out the program. It's really important to make sure that everybody on the team knows what is expected for them and what duties they will perform, and that is sort of streamlined so implementation team can roll out in a way that is very systematic. So then the unit team and those roles and duties, and it's really good to involve the whole unit, and I would say even to involve your EF or house cleaning people that are around. We've used them within our team to help prevent falls in what they do in their daily work. I have some 5-minute video that you can get from this group that talks about fall prevention for others outside of nursing, and I've played it for many different teams, be it the nutritionists, the physical therapists that come up to the floor, EVF, because they all do something within their group to help with the nurses to prevent falls. And then, of course, the unit champions and their roles and duties, and these are people that will get any new info out to the team, and they need to rally around the intervention, so it definitely works. So, implementation team, roles and duties. Design and implement your fall prevention program. These provide daily direct patient care. So you want your LVNs, RNs, and NAs, or nursing assistants, involved. All know what the plan is, and when it changes, it's very important if the plan changes that everybody knows what those changes are and what it means to him or her. And conduct fall risk assessment. I said we use the Morse. We do it every shift. It is a rolling benchmark, so it's really important for your teams to know, and the nurse also is doing the fall risk, that a patient might be a fall risk in the morning, and then maybe you give them some pain meds or diuretics, and they go up to a high fall risk category. So what are you doing about it? How are you preventing a fall at that time? So you have to change your program, at least for that patient, and your team know. And plan care to prevent falls. So I said make it individual to the patient, know the past history of the patient and the present history. What will cause a fall injury if the patient does fall? So if, patients have high INRs, low platelets, a history of osteoporosis, these are also important facts in knowing that for this particular patient, if this person did fall, they could get a bleed, they could break a bone. So what are we doing in case they do fall that it won't equal a bad injury? And then care is performed and documented. This is really important. People do the work and don't document it. And then also, too, when you're reading the chart, you can definitely see what has worked, what hasn't worked. We do a end of summary note, and we put fall prevention as one of our categories in that note, so you can write things specific about that patient and what the plan was for that day and how it did work or go. Strategies for unit team roles. So clearly define each team member's roles. Said systematic way, targets what each team needs to do, which duties are new. So if you're, say, rounding 2 hours and now you're rounding every 1 hour, and actually I recommend every 1 hour because they have done studies and that has decreased falls and increased patient satisfaction. But if you are doing that, then each of your people in the area to know that this has changed. Also, if you have a toileting plan, we're using that quite a bit on patients, all our patients in the hospital, just because falls many times are caused, at least in ours, we've gotten about 75 to 80% around bathroom type activities. So make sure that everybody is aware of what it means to have a toileting plan. Comply with state practice acts, so know your state practice, what it says, how to overcome barriers to filling roles. So for us, we've actually connected roles advancement. So we have some of our nurses that are clinical nurse 2s that are trying to move to clinical nurse 3, and for them to do so, they have to be involved in certain projects. And so a lot of them are very excited to be a fall champion. And how to orient and monitor temp staff. This is really important. These are the float pool staff, the registry, the travelers. How are you going to orient these people? A lot of times they might come to a floor and you might have a specific fall prevention program for the population of the patients that you have on the floor, and if they don't know about it, then they're not going to obviously perform in that way. Also, you have certain types of equipment that you use to make sure that not only do they know what it is, but where it is and how to use it. It's very important that somebody, hopefully the fall champion, a lot of times our champion is the charge nurse, really connects to the float pool or the traveler. We don't really use registry much, and gives them the information. So unit champions. So number of unit champions depends on hospital needs, but 1 per shift is optimal. As I said, we use a lot of our charge nurses, and it's a good place for us because they interact with all the RVNs, all the RNs and the staff on the floor. So they're a good choice to get information out and to oversee the running of the program. And And try to have at least one main bedside RN. It's better to have more than one. Our charge nurses do actually do bedside care. They break release, so they actually are in the trenches, knowing what it is that the other nurses are participating in, so it's a good choice. Assistants, our LVN, should be involved too for buy-in from those groups and for teamwork. They're vital for fall prevention. Make sure they know what the patient's fall plan care is. They really do help a lot. I know in my career before I was a nurse, I was a nursing assistant. I was involved in a lot of ADLs, a lot of assisting patients to and from the bathroom, and to be involved in a fall care plan was vital for me to do a good job on that floor that day. And it's best to have long-term champions and backups. With our champions for about, well, once they are a champion, that they should put in at least a year. And I do track who comes to our committee meetings that we have once a month, just to see if a floor doesn't have a champion there, that we can talk to the unit director or manager to find out if we can have more backups or why it is they don't have someone represented. And we usually have our fall committee meetings in the morning at 8 a.m. so we can catch the night shift too, so it's not just a day shift type of activity. So champions. So role-based professional practice skills. So crucial conversations. They really need to know that. There is a book called Crucial Conversation, and the author's Carrie Patterson. It's a great book. We've used it in for our nurses here and people that especially are champions of either, fall care or champions of other type of events like pressure ulcer, that type of thing, because they're going to have a lot of communication with other members of the team and staff, and them to really know how to do that in a way where a message gets out and people really want to follow what is being said. And effective links to other staff members, respective peers, so that's the type of person that will walk the walk, not just talk the talk. They see the champion out there in the trenches doing what they're asking others to do, then they will follow. And I've noticed this even myself, even though I am the subject matter expert in the hospital, I really get out there and really connected to the staff if they need help coming up with a fall plan of care for a particular patient, etc. And then a positive image of their unit. We definitely want people to say, oh, we can do this, as opposed to nothing ever works. So you really want the person that really feels that their unit is progressive and that this type of program is going to be successful. And problem-solving skills. So every patient is different, and make sure that you have the one-size-fits-all when you're putting together a care plan. So you have to really look at the patient. You have to really look at the situation and come up with good, as I said, good problem-solving skills and to solve the situation. Ability to work with all key stakeholders, and knowledge and passion about fall prevention. I'm incredibly passionate about it. A lot of my champions really are. These are the people that will get the word out because they sort of live it and breathe it and really enjoy all you can do. And when you prevent a fall or prevent an injury, it just makes you feel really good about keeping the patient safe. So more unit champions' roles and duties. So help implement fall prevention activities, serve as a liaison among teams, resolve issues related to falls. So we look at your mini root cause analysis tools. I know we do this on our floors, and come up with what's happening on that floor overall. Sometimes we're able to put a plan in place that resolves some of the issues because we're seeing over and over this certain thing happening with this patient population on that floor, and how are we going to correct that? Serve cheerleaders and go-to people, and be familiar with the program. So what are the goals, the care processes, and outcome data? It's really important that the outcome data get out there. So we put ours on dashboards. You can put it either in the break room or a place where everybody sees it, and to make it the outcome where it's readable, so even your nursing assistants and VNs, everybody can read it. It makes sense of how your floor is doing. We put 2 outcome measures out. We not just do the amount of falls we've had per month in that area, but also injuries, because injuries are so important. And for magnet status now, if you're going for magnet, it's not just about how many falls you have, it's more about how many injuries and have you decreased your injury rate. So maintain and transfer current knowledge of fall-related injury issues, technology, and best practices. So we have people in our group that we keep up on the literature, and I know in our falls community we actually pass out literature at least every other month on what's current, what's new, and to keep us up to date. And then track unit injuries and close calls. Close calls are perfect because they're such learning points of what could have gone wrong and just it didn't, but it almost did. So can we put in place so that close call won't happen again? And then serve as your expert and resources for managers, supervisors, peers, patients, and families. Very important, patients and families. For a fall program to be successful, you really have to get your patient and families on board. Conduct ongoing environmental surveillance, especially while walking around your unit, because that's something you can do all the time in your mind as you're performing other duties. And then help conduct outcome audits. Peers, managers, patients, and families. So you conduct staff in-services trainings on topics related to fall prevention. So you have to come up with what you're going to do your in-services. Actually have a systematic way to make sure that all your staff is actually being trained. So a lot of times we do them maybe in a break room on days and nights to connect with our staff and ensure that they're checked off, that they actually receive the training. The unit orient new employees to fall prevention. So once again, the floats and the registry and the travelers. We actually, when new hires come into the organization, I give a lecture about our overall hospital fall prevention program. So I target each of them as they're coming in. And then faculty-wide participation in new employee orientation training, which is what I just talked about. Train co-workers on new and existing equipment. One of the things about the equipment is I really recommend that you put it all in one place on the floor, not really in central. Sometimes you might order a piece of equipment and it doesn't come up for a long time. So having it up on the floor not only gets the equipment to you more quickly, but also you will use it more because you see it. And actually have on our floors in the utility room all the falls type equipment, and I actually have a laminated card of what each piece looks like because they're in boxes, and that way somebody can like target what it is that they want. Or assist in completing of equipment competency assessments. If you don't know how to use it, you won't use it. So it's really important that your staff know how to use the equipment. So even if you're using, say, a bed binder or a chair binder, if you don't use it correctly and you put the Velcro in the back so the patient can't do it, and do that, but that's a restraint. So you have to make sure that you do all the things within your policy about restraints in regards to that equipment. If you put the Velcro in the front and the patient can undo it, then it's not a restraint, but it is a reminder for them when they get up to definitely put on their call light. And we've used those pretty successfully here at Ronald Reagan. And assist coworkers in patient-family training as needed. As I said, it's really important to get the family and patient on board so they know why you're doing what you're doing and how it's affecting them, so make it very personal to their situation in the hospital. At a unit level, ongoing communication and reporting, integrating fall prevention into ongoing work process. So every round, even if you're rounding and you're looking at, say, you're giving pain medication to the patient, what is it going to do to the patient that might make them higher fall risk, and what are you putting in place? So you're constantly doing this throughout the day in your rounding practices at the same time as when you're providing care. So don't just go in and give the medicine and not think about how it affects other things. So communication and reporting, that's within the unit and among implementation team, unit team, and senior management. So it's got to be a program that's from the bottom up and the top down. You have to really have your leaders that support it and rally around it, and that you need to have the information from the people that are actually doing work at the bedside, so that can come up of what's not working. So then, and the leaders are involved to want to make it work, so then they can make more strategies to sort of tailor it to fit better with maybe a unit or maybe even in a hospital-wide program if it's had a hard time getting on board with it. And then communicate and report. So unit champions give updates at regular meetings of the implementation team. What is working, what is not, what is being changed, those type of things. Unit manager gives updates using data they gather from staff. And you need to talk to the staff to see how the program is working and to get some suggestions. So you might not be out there doing the work, but you need to be talking to the people that are doing the work. Staff documents falls and fall risk on the unit sheets. And we actually have documented, because we actually have a program in our hospital that is volunteer nursing students, and they go up to the floors and they help in, it's called a Fall Ambassador program, but they help the nurses, care partners, and LVNs and look what they can do. So if they see a door that is closed or curtains that are drawn, they'll ask the nurse, is that okay if we open the door or open the curtains for direct line of sight? And so they actually get the fall scores of the patients on the unit, so they can direct their attention to ones that are considered high fall risks. And it's actually very helpful, and our staff is really happy to have other people in the trench, like purposely looking for fall prevention and people on the unit that could have a fall event, and that they're able to turn it around, as in a patient getting up to use a mode and didn't put on their call light, and one of these volunteer nursing students, as they're walking by, sees that, so they'll put on the call light and make sure a staff member comes in right away. So staff should share important patient safety issues and changes in care plans during 5-minute stand-up meetings. And then ways to communicate and report: share risk assessment information during shift reports. So we actually, at our hospital, we perform bedside reports with the ongoing nurse giving report, the outgoing nurse giving report to the oncoming nurse. And so they do involve the fall risk and the fall care of plan right there, and the patient and the family members are involved too. It's a really good time to go over it and get some feedback from either the patient and the family too of how the plan is working. Tell the patient and his or her family if the patient's risks change. And this is very important. As I said, say you come in and you give a diuretic to the patient. Well, yes, their risk is going to change because they're going to get up more often and they might get up more quickly. So what are you doing about it? Is the family aware so they know what they should be doing? The patient, if they're a high fall risk, needs to go to the bathroom with a staff member, not on their own. Are you coming up with a toileting plan so that you're in there, say, maybe every half hour for a bit of time after the diuretic is given? You shared that with the family and the patient. Communicate and report. So the nurse assistants that have guidelines and tools for reporting new falls or risk problems, such as a tablet with pull-off pages, including the patient's name, room number, and date time to be given to the designated nurse. Patient and family fall information on admission. We do give that. We also have taken the extra step of providing information about falls in our ambulatory areas before patients even get into the hospital, just so they're aware that it's something that's really important to that when they are in the hospital. And some of our floors have different types of fall information based on their patient population. So to make it more site-specific to that area is more helpful to the patients that are seen on that type of unit. And then also staff pocket cards to remind them of best practices. So, patient reporting, it's got to be regular, it's got to be thorough, and done with minimal time and effort. Make it a part of every day at work. Very important. And keep fall and fall prevention. So, strategies for ongoing work processes. Make some practices universal. We pretty much talked about in the beginning of this talk. Incorporate change into routine care. You don't want static care. Every patient changes with time. Integrate fall risk data into your regular communication, such as handoffs. I talked about that in our ongoing and offgoing nurses, how they do bedside reports and talk about fall risk. Also, we have a banner that goes on our electric health records on the front page that even the physicians, physical therapy, anybody that goes into the patient record, where if there's high fall risk, it turns up yellow. And we also have a fall risk category for our physicians and our teams as they round, so that they're involved in talking about what they can do within their job description to help decrease falls. Place visual cues or reminders about care plan above the patient's bed. Direct the patient and family to this also. It's good to remind staff. Something that we've done with some of our patients, not all. We had some issue with, you know, it becomes wallpaper if there's too many other things up on the in the room. So really think how you can make it stand out so people are directed towards it. Talked about the electronic health records and how we're using them. So example work processes. Conduct a medicine review on all newly admitted patients using a pharmacy risk scale to determine the need for a full pharmacy evaluation. You know, can some meds be discontinued or changed to a better hour? Like maybe you have some that are given at night. Maybe it can be changed to a different hour so the patient, so if it's a diuretic or something, so the patient's not getting up at night when the room is well lit during the day, and they're more at night also. Use a standard order set for all patients to institute appropriate mobilization protocols, and give all patients noted to have a change in mental status a delirium evaluation bundle to determine if they need for increased supervision and further medical evaluation. Of ongoing work processes. Post-fall assessment note as a structured electronic template or paper progress note to guide nurses through appropriate care processes. And this is a guideline of what to do, like after a fall. We actually have a full guideline that you know, the nurses can print out. It's a one-page, so they know exactly what they need to do in the order after fall has happened. It's been very helpful. Use hourly rounds to assess toileting needs and other concerns, as I talked about the toileting plan. And one of the things even in our organization is, I know a urinal for men, we've realized that many men do stand up to use that urinal, and we've actually had falls from them getting up without putting on light to ask for assistance. Even if you are using a urinal for your male patients, remember, what is that toileting plan? Does that patient get out of bed to use it? What does that patient need to know as far as when they get out of bed? Do they need to call you? So really think about that in every piece of equipment or every plan that you have. Conduct regular environmental rounds to ensure environmental safety, and that's, you know, during your 5 Ps, or we call them 6 Ps here, paying personal needs, positioning, placement, preventing falls, and pump. But recently we actually had an incident where the pump, I know we're doing it mainly because of the alarm and to not have the sound going off all the time because it's very hard for a patient to hear that, to get to changing the bags before the alarm goes off. But we also noticed that with our pump, the cords are not placed in a way. Had a couple patients over the last few months that have actually tripped on the cord of the pump. We had one patient who was trying to get to the bathroom quickly, and his pump was plugged in, and so he ran out of the length of the cord, and he ended up falling that way. So really also look at your pump and its placement too. Processes with the electronic records. Most people do have electronic records now, so you can think about these issues. What fall risk factors are already in the patient's record? So look to see in the record what the disease states are. As I said, it could be osteoporosis. What is that going to do if the patient falls, maybe breaks something? The labs that are in the record, high INR, low platelets, also low sodium actually has shown to increase falls. So look at the labs that you have and then think, how do you apply that to who the patient is, and coming up with a plan to reduce falls and injury. What data is in the patient's record that can help you assess fall risk factors? So there could be things that, their gait. We actually recommend now for our nurses once in the beginning of shift to really watch the gait of the patient, because gait can change quite a bit. And if, say you have a person that has bad ascites, that's going to definitely change their gait. And so what are you doing about it to make sure that ascites is not a factor that is involved in causing that patient to fall? Then, of course, hard of hearing patients and people with poor eyesight. The most logical place in the patient's record to collect, organize, and assess fall risk factor data and needed intervention. So make it easy so you don't have to dig deep through the records. I know that has been a problem because there's a lot of things in a lot of different areas. So try to find an area where you can actually put these things in. As I said, we do a shift note, and we put a lot of this in, especially for high fall risk patients. So it's sort of there on the one page. And so we have a lot of information regarding just general back of the patient on the patient story, which is the first page of the electronic record when you go into the patient's chart. New practices. So manage change process, staff engaged and excited, and staff learn new practices. So how are you doing that? Strategies for managing change process. So staff to gain support and buy-in. If not, the program has a high chance of failing. And let staff help tailor practices to your hospital. So they're in benches, they're doing the work. So come up and ask them for their ideas. These programs, you have to say, we're going to have a program. That is something that is not negotiable, but we're going to do certain things is negotiable, and you get a lot of buy-in from staff. Make staff have the time, training, equipment, and supplies they need to adopt new practices. So have a great program if you don't have this type of setup. If you don't know how, as I talked about, you have equipment, but you don't know how to use it, or the equipment is hard to get. Supplies are hard to get. They're not going to use them. So make sure that you come up with what it is that you're going to do in your areas to have stuff really available and to have people trained on proper usage of the equipment or supplies. Implementation team roles in managing change process. You guide, coordinate, and support changes during the pilot phase and rollout. It's very important to have a pilot phase to see how it's going before you roll it out to all the different areas, because it's going to be, small, 1 or 2 units. See how it works. What kind of changes or things need to be adjusted. Don't ever roll a program out throughout the hospital until you work with pilot units first. Work with staff, clinicians, and managers, and senior leaders. That's that whole thing of, the bottom up and the top down, so that everybody's on board. And work with union youth champions to create ongoing monitoring processes that gather feedback from the staff and clinicians and come with a way about how you're going to gather feedback. You know, you might have a box on your floor that people can put some feedback in about the program. Come up with a way that you can gather. And tracks changes in fall rights and interventions. So what kind of intervention did you do, and did it decrease falls in your area or on your floor? We had a couple of programs on different units that have decreased fall rates on their unit, and so we've used those to spread to other types of units. Communicates results to staff. If you don't have the results out there, then people don't know that you have a program. So that's the dashboards where it's easy to read, and it's in an area where staff, either accommodates, is readily available for staff to see. Rollout or pilot testing, have implementation team or unit champions meet with unit staff on all shifts, and this shows unity or unit level improvement team. And new roles and duties, so during this meeting, and just how to adjust roles, tasks of communication and reporting. Managers and administration nursing team, and how to address and overcome barriers to adherence. So staff out, say we will do this, but we can make some vacations if necessary. Fill out our pilot testing, remind staff of reasons that fall prevention is needed, safe patient care. This is a time where you really want to show that in preventing falls, you can actually increase the quality of the patient's stay in the hospital and even the quality of their life. Involve staff in identifying problems and testing solutions, so you need that for buy-in, and keep staff informed about the program's progress. So that's very important. It keeps the program highlighted, and for it to be inculcated and for sustainability, you really want to keep staff informed. If you resist changes, find out why they are resistant. Don't just, there might be really good reasons, and it might be other areas that are resistant too, but they don't actually tell you. So you want to make it where people really are open about their feelings, so you can take those into account, and include fall prevention in staff performance evaluations. That's very important. If resistance is widespread, then find out why. There might be competing priorities, etc. Maybe it is that they really don't know what's being asked for them to do, and change practices or the implementation plan to address their concerns. This is very important. If there is resistance, before you roll out the program, that you really get it where you're going to have people that are resistant to it. So what can you do? It might be a few things you have to implement or change in the way that you're going about the program for the resistance to not happen. And do full launch if needed. It's always important not to put out a program that isn't going to work. If you have to go back, for most programs or any program that I've worked in, it's better to go back and really remember that it's going to work well or before you get out. Just because you put a lot of work into creating the program, if you're having problems with it, it will not roll out very well, and you'll be back to the start anyway. So you might as well do this up front. Helping staff learn new practices. Work with the staff education department and other key stakeholders to assess staff knowledge of fall prevention. So that's the critical thinking part. And I have videos, I have 4 of them that created that is about this whole staff knowledge of fall prevention, and they start and stop, and staff can put their input in as they're watching the video. So you really get sort of an idea of how they critically think and get them from the group. And identify knowledge gaps, create an education plan to address those gaps. Adults learn best through methods that build on their own experience. So those scenarios that I created, and I actually had the floors. I created ones that were not too in-depth, like say a liver patient, but it was the liver transplant floor nurses that actually came up with the script and the scenario based on the type of falls they were having on that floor. Or the medicine floor, we had a group get together of clinical nurses that looked at their mini root cause analysis, post-huddle audits that were done after a fall and came up with a scenario. So that way there was a lot of buy-in because they were part of creating these and have a variety of learning styles and skill levels. So use variety of education methods, didactic and active. Active learning is best. If you look at, there's a man from way back in the beginning of last century named Ed Dale, and he had this zone of experience, and % of what you read, you remember. 20% of what you hear, you remember. But if you keep going down, 70% of what they say and write, they remember. But if they actually do something, like 90% of what they do, they remember. So it's actually getting people, so that's the simulation, some of the videos that I created. So they're those type of, you're actually participating in a way where you're being nurse of that patient, and you'll remember that experience. Today about key elements. The Fall Prevention Program, staff roles and duties, organizing a plan at the unit level, and training staff on all new fall prevention practices. Please refer to your QI specialists, and here are our resources for this presentation. Thanks for listening.